Okay, I'm sure that more people are going to come in as they come out of the sessions. And there are people hogging the back row. I don't know whether I could encourage you to move a little bit further forward so you can leave space for people who are going to come in later. None. You have now a fantastic opportunity to ask all those questions you were too frightened to ask in the big hall. It's very informal. And you can see we deal with a range of topics here. So who would like to ask the first question? Great. I've got two people wanting to ask the first question, so we'll go further in the front first. The benefit of sitting close to the front.
Please. No more questions.
Too tired. I take this microphone. Solid. Jolt Varga, working in Sweden right now, and I've been a little bit of confused actually with a session we had, which was actually a really good session, but it was a little bit of conflicting presentations in terms of what shall we do with post-operative controls after EVARs, and how often shall we do, and is that really evidence for do pre-discharge CT angiogram for all the patients, and if we do so, is it the fashionable issue that cost effective? How much shall we pay for a saved life?
Okay, they've got quite a lot to answer. Is that the nub of your question?
Yes, it is.
Did you pay for that question, Janet?
No.
Okay.
No, but I paid you to have a first go at response.
Okay. Shall I?
Oh yes,
Shall I say something?
that's what I paid you for.
Well, it's amazing to see that in presentations, but certainly in the literature, there is a big room for interpretation, because there is very few level 1 evidence. That's as simple as that. And even if we do the best randomized trials, and there are a few being done, maybe even in this country by some people, I'm not looking at anybody in particular, but there are still people challenging the outcome, the results, the quality of the outcome events. So, we will continue to go on fighting it. That's what makes it nice, because that's what makes these congresses go on, I guess. Otherwise, we would all sit at home, know the answers, and not have to go anywhere. But what I want to say without laughing now is there is room for interpretation. We have findings, and we interpret them, and then somebody else does another study, and he has findings and interprets them differently.
Joss, what do you think?
Well, I demonstrated this morning an overview of the literature, and one of the problems interpreting everything is that you can pick one article that's talking about one specific stent graft, another one talking about another stent graft, and is this all applicable to the whole family of stent grafts that are currently available? That's the big question. I think that we still need at least one CT after the implantation, whether that is pre-discharge or after a month or after 2 months. That's something that you can discuss. But I think you need to have some kind of point of takeoff.
Yes.
It does make a huge difference if it's a discharge CT or it's a 1 month CT. It's a totally another beast. It's not the same.
Can I challenge?
Quickly, yes.
Yeah. Well, we are currently doing a study, and we've included 100 patients to see whether we need that first post-op CT. And I'm not even saying whether it's after 1 day, 1 week, or 6 weeks, or 3 months. And quite honestly, we think we don't need it. And there are a few reasons for that. One of the reasons that was never alluded to is that the intraoperative imaging quality has improved dramatically since the last 10 years. We can now do completion angiograms that show us much more. We can even do CT scans, Dyna CT scans on the table, which means that you don't need those investigations, probably in the aneurysms where you are happy with your completion angiogram, and provided that they had the right anatomy. I'm talking about non-large necks, non-dilated iliacs, not too much angulation, and the neck that is long enough. Because in those patients, you virtually certainly, well, you almost certainly know that it's fine.
I think there's definitely a role for cone beam CT in the future in this regard, and that might substitute completely the initial CT scan.
Okay, question 2 rows further back.
So, my name is Kiskinis, I'm coming from Greece. I have a very practical question. Last week we have a very young patient, 40 years of age, with an acute dissection and ischemia of the right leg without pulses in the femoral artery. So we make an angiogram, we have find out that the left renal artery was occluded, the superior mesenterica was occluded, and the common iliac on the right side was occluded. So we put an endograft 15 centimeters in length. We occluded the left subclavian artery, and after that we have find out that we have pulses in the right leg, but not perfusion in the kidney and the superior mesenterical artery. What is your opinion we must do as a next step?
Thank you. Who would like to take that one first whilst I invite people at the back to come and sit down? There are plenty of seats at the front. Okay.
There is nothing more difficult than an acute type B complicated dissection. The reason for that being that you know when you start your treatment and you don't know when you end it. If you're lucky, you will put in your stent graft just past the left subclavian and everything will be revascularized. If you're not lucky, you have to go down. And that may include extension with stent grafts or with TXD devices, non-covered stents. And that may include fenestrations and revascularization of the vessels. Obviously, you have to do that in the acute complicated situation to have enough options to save the target, in this case the renals. I mean, the SMA will be perfused through collaterals, or the gut will be perfused through collateral. But if it's complicated, you have to go till the end, so you have to continue on your treatment.
I'm going to have another quick comment from Stefan.
Yeah, just wanted to add, did you only perform the angiography or did you have CT images? Because then you might have actually...
We have made CT before going to the operating theater. But we have not the possibility to make in the operating theater CT, only angiogram.
Okay. So did the patient had any signs of bowel ischemia, clinical?
Yes.
Okay. So, and I think we're on the same pace here. You first start by implanting an endograft to cover the entry and then try to get access to your occluded target vessel through the tear of the insomal flap and try and stent them, because you have a dynamic malperfusion and a static malperfusion that can be added. So if the stent graft is not enough, then you need to be quite aggressive at trying to restore flow to all those vessels.
So how long you think we must wait? Some hours, or we must proceed during the same operation?
I'm going to finish this one.
So no, I think everything has to be fixed right away, because if the patient has bowel ischemia, you need to fix it really fast. Otherwise, your mortality rate, the risk for mortality is going to be quite high.
Okay, thank you.
Okay, do we have some more questions relating to the abdominal aorta, or do people want to come back to the issue of surveillance after EVAR? We've got 2 more questions.
Yes, I'm Laurent from the Netherlands. I have a question about the presentation this morning. I was a little bit puzzled about the 40% sac enlargement after EVAR, after 3 years. And I was wondering whether or not, how do we identify patients who has to be treated, which have a sac enlargement without a type 1, or evidently what type 2 endoleak?
Right. You're going to pick that up first, Andreas?
Sure. Yeah, so first of all, just to clarify, I was at 5 years, not at 3 years,
Okay.
for what it's worth. And then, how to pick those up, the answer is they need surveillance. And I guess in reference to the first question, I don't think we know exactly when they need surveillance, but what we do know is they need surveillance. We use a protocol that's generally 1 month, 3 months. If it's okay, I'm sorry, 1 month. If it's okay at that point, we just skip to a year, which is consistent with the Pittsburgh paper, and then annually thereafter. But to the second part of your question, 30% of the patients had aneurysm sac enlargement in the absence of an endoleak. So I don't know exactly how to explain that, but I can tell you that it is a significant proportion of patients, and I think that's consistent with other studies.
And they will be just surveilled and won't treat it.
Well, again, in this data set, we don't know what treatments they received after demonstrating aneurysm sac enlargement. We would treat that. I mean, we would try to identify an underlying etiology and treat that.
Thomas, would you like to comment?
Well, I guess that you still have a high rate of aortic sac enlargement nowadays with, so to speak, newer or brand new devices. Just reflects that probably the use of those devices as an EVAR are sometimes overstretched. And not what we presently probably don't know is more variables that define perfect anatomical suitability. It's probably factors we don't know that affect this.
That answered your question.
Thank you.
Two
Thank you.
rows further back,
Okay.
please.
I'm Lu from China. I ask to all about the migration because did you some patient after EVA the migration most downward, but did you made some patient after that upward migration upward? It's my question because I made some patient after the EVA, we find some migration is upward. And there are some devices designed just to use the hook or pin or some things to catch the neck, but it's to prevent the migration downward, but never upward, prevent upward. So this is my question.
Right, who's seen upward migration?
I've never seen this.
I never have.
I've never seen upwards migration, but my very esteemed predecessor has talked about upwards migration. What I have seen is during the procedure, if you have the ideal anatomy, which is very straight iliacs and a straight aorta, then you can push your graft up, any graft up, especially those with columnar strength. If you hit a limb with your sheet or your limb, so you have to be careful with that. But I must say that during follow-up, I haven't seen any migration upwards. Of limbs, of course, in the old days, especially with the vanguards, we saw that. The fire hose principle, upwards migration of the limbs was seen quite often. And I don't know why we don't see it at all with modern devices, actually.
Have you seen it in the M2S at all? Not in 10,000 odd patients?
You know, specifically, we didn't look at that because you can't look at fabric above a renal. That's not one of the things we assessed.
To me, I think it's not because the angle of the proximal neck. Maybe sometimes because the distal. Some iliac very tortuous. Maybe I just find for this patient I find some upward, the iliac very tortuous, and we put some to focus to fix that. After that, during the follow-up, we found it's upward.
He's talking about something different. He's talking about iliac migration.
That's very interesting, but I don't think the panel is able to help you on this matter.
I think he's talking about iliac limb migration upwards, and that's something we know, of course. That's totally different, and there are some grafts that have bare stents distally or little reversed hooks to prevent that migration.
Right at the back, please.
I may say that I'm from Israel, Sandro. We had 2 cases of proximal migration. So these cases do occur, and we had a perfect completion angiogram showing both renal arteries. And on a follow-up angiogram after a month or so, 3 months, I don't remember now the timing, one of the renal arteries got covered by the stent graft and only one stayed patent. So this is something that happens rarely, and it is also described in the literature.
Thank you.
Gabi, can I challenge you on that one? Because is this just a graft that is sitting half over a renal artery, and when you do your first control, the renal artery happens to be occluded? Or do you think it's really the graft, which we cannot see, that has migrated upwards? In other words, did you catch the renal artery, and in the initial angiogram under heparin, you still saw the renal artery filling? Maybe if you go back slightly less or slightly later, and then when you do the control CT scan, the renal artery is occluded.
Completion angiogram showed both renal arteries. Pre-discharge CT scan showed both renal arteries non-covered, and the repeat CT, which was taken a few months later, showed covering of the first renal artery. But I'm not that surprised, because shrinkage of the aorta is not only in the lateral diameter or the AP diameter, it shrinks in the longitudinal ones. All the anatomy is changing after a good sealing and no endoleak. So some grafts, as I understand, may be pushed upwards with this, although it occurs very rarely.
Thank you for that. Next question. Got questions? This is the purpose of this. It's your opportunity to ask questions in a small environment. And if you're too embarrassed to ask them, you can write them down on a piece of paper and ask one of the striped shirts to bring them to the front. Question in the front here.
Just want to make a comment about the issue of the pre-discharged CT scan. The facts we've got from Thomas, I'm sorry that he didn't speak up, but the facts we've got from his data are that five got problems, some of which died, and there was another one at 32 days. I think the question of how long, Eric, it should be and whether to do it or not, I'm sure you're right that if in modern times there is in the operating theatre CT scan that is equivalent to, at the very end of the procedure, is equivalent to a pre-discharge scan, which wasn't available, as you rightly say, years ago. That's number one. Number two, we have, however, got to be suspicious of the completion angiogram, because the timing in that is not always perfect, particularly in the less experienced. So obviously what's happened in the patients that Thomas is talking about is that they've looked at a flush angiogram, haven't seen a leak, it has been there, they have gone home, because bear in mind, about 1999, there was a tendency to boot people out quickly. The likes of Jacques Blind talked about what Barry Katzen was talking about, doing it as an outpatient procedure, and so many died. So we now know that you've got to take steps, otherwise some will die. Because of modern technology improvement, it hasn't got to be necessarily a pre-discharge scan, but I think it's sure got to be a CT scan before, soon after the procedure's done, and not at the follow-up of, say, 3 months or more. Otherwise, I think it's fundamental that you're going to have some deaths. And on the question of cost effectiveness, I think that's rot. First of all, you've got to do the right thing to save lives and stop people dying unnecessarily, and that will automatically contribute to cost effectiveness.
Stefan.
Thank you, Roger. Can I answer that, please?
Well, can we have Stefan first and then you
And
this time round?
Of course, Janet.
Thank you, Eric. So I think there are two main reasons to do a post-operative CT. First is to have a reference image for the follow-up, and the second one is to treat an early type 1 or type 3 endoleak. How many patients do actually need an early reintervention? It's very low, especially in high-volume centers. So when do you need to do it? Is it just before discharge at 1 month? I have no answer. The problem of doing a very early CT or doing at the end of the procedure a 3D rotational angio is that you've already injected a lot of contrast during the procedure and that you might have renal issues. So probably in the future, with the fusion and with the new tools that we'll have in the OR, the volume of contrast that we'll need during the procedure will really go down, and then maybe we can do the angio CT at the end of the procedures. Having said that, the patient is under high-dose heparin, so maybe you'll find a leak that would have spontaneously sealed over the course of a couple of days. So
And Eric wanted to comment
Sure.
too.
Well, I agree with Stefan, and I take your point, and even very seriously. But if we go back in real life, how many times do we do something with that first CT scan? The question is, do we find a type 1 or type 3 endoleak? Well, I would challenge that you won't find a type 3 endoleak if you do a good procedure. Long overlap, long sealing. It's, Roger, hang on a second, please. Wait a minute. Don't give him the mic. Let me answer first. Roger, please. Okay, thanks. Okay, I'm in trouble.
Well, otherwise we'll take the microphone away.
You won't see me next year at Charing Cross. No, I'm joking. No, I agree, but, let me put it very practical. What we see now at the end of the procedure in the completion angiogram in perfect hybrid suites is totally different from what we did in the years before. Actually, the completion angiogram 5 to 10 years ago was useless because nobody looked well. Whatever you didn't see, well, it was okay, and then you went on to the CT scan. Nowadays, if you do the CT scan for a reference, knowing that you had a perfect CT scan just before the procedure, knowing where you put your graft in, and with a perfect completion angiogram, I would challenge that you don't need additional CT scan. But I add, in the well-selected patients or the patients with a suitable anatomy. If you do patients because you have no better choice who are fairly unsuitable for EVA, I would certainly agree to do an investigation to know that you did a good job. But if you have, let me put it that way, 5 centimeter long iliacs that are 11 millimeters, a 3 centimeter long neck of 24 millimeters in diameter, you don't need it. Please go.
I just want to add something. Eric, you're doing hundreds of cases a year. You have a perfect imaging system. So what is a rule in your center cannot be a rule in a center that performs 5 cases a year. And I think that's an important point.
Now, if I'm going to speak, because I'm going to have to leave after this, not because I'm irritated by anything Eric said. I, however, cannot resist telling Eric that to be at Charing Cross is a great pleasure for us, but it's also to be amongst the highest form of life. And you'll always want to be amongst the highest form of life. Yeah. So let's just accept what Stefan's implied. Yeah, we all don't have what Eric's got. We all don't have what you've got. We all do know that patients are dying early, and they're dying of things we know not what. There could be type 1 endoleaks, type 3 endoleaks, type 2 with sac expansion that we don't know if we don't do appropriate checks. The point is, the suspicion is that some patients are rupturing, of which 2/3 are dying, of what has been over those years, and some are as recent as 2005, inadequate proof that everything was okay at the moment they were let home. That's the fact. Now, I don't mind how we check it as we become more sophisticated. My only point is we damn well got to check it, because we've got to be damn well sure that when they walk out, they ain't going to die walking down the street. Otherwise, it ain't good.
But a completion angiogram nowadays is a valid check.
Well, I don't see you as a radiologist, for a start. And I see Stefan surely can talk to that. But I think it's a bit dodgy for us to say a completion angiogram today is fine. Isn't there something to do with timing? The facts are that you've got to be sure whether you can do it with a completion angiogram, as everybody thought they could in the days of EVAR trials, is open to discussion. I want to be on the safe side to stop patients biting the dust.
Okay, we've got 2 people wanting to ask a question. Do either of those 2 questions relate to this discussion we've just been having? Yes, if this one does, we'll take this one first and I'll come back to you.
This is only a comment, really. This is a really prestigious meeting, and everyone's coming here to have a message to take home to alter the practice. And in a real world, we don't have that good facilities, that much experience, and that much confidence and possibly even that high wide shoulder to take all, even one death out of 20 in a year. So if there is sufficient evidence suggesting for the time being and completion CT angiogram which can prevent life, can save life, then we should strongly recommend to all who works in real life.
See you later, Roger. Again, I totally take the point that not everybody is that experienced, that well that well equipped, etc. Now, to be honest with you, my patients don't die after the procedure. The only thing we are doing now, and we have finished that study, is to check in our series what the first post-operative CT scan made us change for the patient. Did we 100 times say, it's perfect, it's fine? Did we discover type 1 or type 3 endoleaks that were unexpected in comparison to the completion angiogram and the post-operative duplex ultrasound with contrast or without contrast? So we have a completion angiogram, we have an ultrasound, and we compare that with the first completion CT. And the question is, did we find something interesting?
But your experience is not showing the real life.
Well,
Real life is what matters. You know, a center of excellence. It's very difficult to base on an everyday practice.
Oh, that's fine. My message to you as a small center is, if you do the suitable patients, you won't have problems. But if you're in your small center, you attempt to do the borderline patients, then please do me a favor and do a CT scan, because you want to be sure. But again, if you have the perfect anatomy and you use one of the standard modern grafts, I don't care which one, and you have done a good job, you know that your graft is just below the renals and sealing well in the iliacs, and you have enough overlap with your limbs, my personal idea is that we might not need the CT scan. I'll come back to that when we have the study finished. But that's, you know, my opinion.
Okay, we've got somebody at the back who's been waiting to ask a question for quite a while.
Hi,
Go
this
ahead.
is a question to each of you to give your own personal advice. Just over a year ago, I thought the evidence was moving in such a way that the only indication for open repair for an aneurysm would be anatomic unsuitability for EVAR. Following last year, now this year, I'm not so sure. And I wondered if you can tell me what kind of life expectancy for your individual patient you would have as an indication for open repair. Is it 15 years, 20 years, 30 years, or not at all? For open over endovascular when it's anatomically suitable for both.
Can I add to that to ask from the panel, because it's tied into it, how long they expect an endograft to last? So perhaps they can tell us both at the same time. And let's start at the far end with Thomas.
Well, it's a difficult question to give you a threshold.
That's why I asked it.
What I just learned from the data I presented this morning is that you can still rupture if you have an EVAR. And if you get the open repair in the setting where everybody is supposed to be suitable for endovascular repair, as the EVAR trials did, then it is protective. The anatomy being suitable for it is protective even if you get an open repair.
Eric, never shy of an opinion.
No, I'm in the wrong room, obviously. I can't believe my ears. I mean, we have a procedure that has shown to be equivalent to open repair. There are problems with any of these two repairs. We should see them beside each other. And again, if you follow the patients, you exclude type 1 and type 3 endoleaks, you shouldn't have ruptures, or very, very rare. I think for your patient, to answer your question, for each individual patient, we need to find the best solution. That means that we have to balance the pros and cons of each option. There are patients with suitable, but not very suitable anatomy for EVAR that are much more suitable for an open repair. Think back this morning at these very angulated necks. Some of the angulated necks are extremely easy to treat by open means. If the patient is a good candidate, I would treat him by open means, no doubt. With regard to the age, I have no hesitation to treat a suitable patient, a suitable anatomy with EVAR. How young he is, I don't care. I explain him both sides, pros and cons in general, pros and cons of his specific anatomy, and if he can have both, which most young patients can have, then they can choose.
Jos.
Life expectancy is not influencing our decision at all, and I expect the stent grafts to last at least 15 to 20 years now.
Okay, so you stent graft 15 to 20 years, so that might match with how long you think someone's going to survive. Andres.
I mean, first of all, I think it's a philosophy question you're asking, but for me at least, it's if they have good anatomy and good follow-up potential, then I generally offer them an endovascular repair, but that's my issue. Their anatomy and how likely I think they are to maintain follow-up long-term.
For old patient or fragile patient, I'm not talking about EVAR2 patients that are dying when they walk out of your clinic. I think we're pushing the envelope for an endovascular repair. We try to find an endovascular way. If we're treating a younger patient, they're very young, obviously there might be a Marfan disease or something else, then it's another discussion. But if we're talking 60-year-old patient, then anatomy is really what we look at. If it's really straightforward anatomy, we know that the outcomes are going to be good with endo, and then we offer the patient a choice. If, as Eric stated, you have a kinked neck or iliacs that are tortuous, then I think those are the patients that have issues in the long run, 5 years after the procedure. So if a young patient with an anatomy that's not straightforward, would rather offer him open surgery.
Okay, we're going to get the Irish solution or an Irish question.
I really enjoyed the discussion very well. Just as a comment at the last between all of you, I agree. Mid to long term is about 12 years because 70% of this patient will be dead already. So we must not look for 15 or 20 years. The patient will not survive that long to benefit. This is the first question. Regarding the post-operative, we haven't done a CT scan in the past 4 years. I never had a problem. Duplex ultrasound scan with the velocity of each limb is the way forward. You could do a contrast-enhanced ultrasound. You see the velocities. If it's below 28 centimeters per second square, you might have a problem. If it's below 16, you definitely have a problem. Plain film abdomen is very good if you don't have this facility in your center. One of the major problems that when this patient arrive to you on an emergency basis after a EVAR, you have already done everything by the book. 6 months, and suddenly bang, they arrive on your bed and you don't know what happened. So the idea of continuous CT scan is a waste of time.
So what's your question?
Do we need to do a CT scan or not? And that's the question.
Okay. Is your question related to that? No. Okay, fine. Well, do we need to do a CT scan?
I guess nobody's going to tell you whether yes or no, because it's got to be a good modality for a test, whether it's a CT scan, whether it's a perfect on-table angiography where you're sure to exclude any problem, then you're fine. But it's not the CT scan, it's a good test, whether that's a CT scan or something else.
But what are you doing? It's you just going about whatever people have done before. You don't need it. You have done a good job. You have seen what's happening. You know your results. Why are you still saying you have to do a CT scan? It's a waste of time and money and a big injury to the kidney.
So why do you do one after 1 month and 3 months and a year?
I never do that.
So you don't do any scans at all?
We do it after 5 years only.
Okay. We don't want to fight here. And I mean... And one of the issues we've already had raised, an interesting issue, is the difference between specialist centres and centres which do a fantastic job but are not quite as huge and well equipped as someone like Eric's in Nuremberg. And clearly, quality of the people doing your duplex scan are important, and not everybody will have the same. You want a quick response?
Yes.
And then we got 2 questions waiting before we finish.
We still are doing the first CT scan up to now. We want to validate it before we stop it. So we do that study, that's clear. We still do the first CT scan as reference, and both in Groningen and Nuremberg, we stopped doing CT scans as early as 1999 during follow-up. Now the weakest link, as usual, is human. We published a series of 358 patients, and in that series, with a duplex follow-up, we had 2 acute events other than limb occlusions. We excluded the limb occlusions, but we had 2 acute events. One highly symptomatic aneurysm or contained rupture, and 1 full rupture. There were both type 3 endoleaks. And going back at the stupid, simple abdominal x-ray in 4 directions, you could see those limbs sliding out. And we should, in one patient, at 1 appointment, and in the other patient at 2 appointments, 2 consecutive appointments at 6 months and 1 year, we should have noted that this limb was starting to migrate or to disconnect.
Hindsight is a wonderful thing.
Excuse me?
Hindsight is a wonderful thing. Stefan, you go.
I just wanted to say that one of the take-home message today is that obviously we all agree that we do not need to do a CT every other month during follow-up, and we're far away, and there are a lot of series showing that ultrasound, contrast-enhanced ultrasound gives us a great result. So there's a real trend in every large centers and every centers in Europe to actually mix CT and ultrasound, and our follow-up protocol now is a discharge CT, 6-month ultrasound, and if everything flies, then it's going to be an ultrasound every year, and maybe at 2 years perform another CT. And I do agree that abdominal X-ray is a fantastic, easy tool, but you need to look at the images because, as Eric said,
there you
go again.
Yeah.
Right, we've got 2 questions waiting, and can you ask a question quickly and hopefully get some quick replies because we're running out of time. First one over here, please.
It's a question about large
We've got
iliac.
3.
About large iliac as a ceiling zone. What do you think about an iliac ceiling zone about 22, 24 millimeters? You go to external iliac, you put an endograph there.
I think at least in the data set we looked at, that was greater than 20 millimeter was a threshold cutoff where you tended to have independent prediction of future enlargement. So I think that starts to push it. So I think if you're using a flared limb of a 22 or a 24, durability becomes a question.
Okay, Jose at the back, and then the lady with the mic. Can you go first, Jose? Shout. No, it's okay. Okay.
This is a question I asked with some trepidation for fear of upsetting you, Professor Powell. I just wondered, when you spoke about the fall in recruitment for the IMPROVE study, I wondered whether one of the reasons is that there genuinely isn't equipoise among surgeons in this country, and whether the answers have already been discussed to some extent in previous symposia. What I'd like to ask the panel is what they would do, what their personal opinion is in the treatment of patients with ruptured aneurysms who present stable, having had a CT with an anatomy suitable for an endovascular repair. What would you do?
Well, I'm going to take first response on that, and I might sound a bit like Professor Greenhouse, but I suggest you listen to the talks properly. I didn't say anything about falling recruitment to a trial. We were talking about the falling presentation of ruptured aneurysms universally to every vascular centre. Now, the rest of the panel can answer the second of your questions.
Sorry, Janet, you do sound like Roger sometimes.
Yes, I know. I did confess.
I'm going to have a fight with everybody. I'm sorry. No.
That's good.
To give you my answer, our first treatment choice is really endovascular, provided, I'm coming back to you now, that you have the logistics to do it day and night, also in the weekend. And that took us 2 or 3 years in Groningen when we started back in 1998, much later than Frank Veet and Brian Hopkinson, who are still fighting, who did the first one. But, it's about the logistics. It's not about the treatment, it's about the logistics. And obviously, I'm not going to say anything about the need for trial or not, but for us...
And it's about resources as well, because many centres would be very willing, but are not resourced.
Yeah. I don't have that problem. I agree.
Can I have the rest of the panel's views as well,
We've taken a very aggressive posture towards endovascular approach for rupture and started a program where it starts with the EMT in the field all the way through to the OR that's notified immediately. So we have the luxury of having the resources in place for 24-hour access to multiple devices and inventory. So, and our results have improved significantly, but it certainly wasn't in the context of a randomized trial.
Certainly within this country, there are real resource limitations, and I think we've only identified possibly 2 centres in the whole of England that can actually offer a reasonable 24/7 service for it. So we've got quite a long way to go. Thank you all for your questions. The main session has restarted. Please go and enjoy the rest of summer sunshine in London. Thank you. Thank you to the panel.